Just to give you a little bit of perspective, when I was a student here at WVSOM, we only had the main building, and the quad building where a lot of offices are was all open air. All of those had been dormitory rooms for the Greenbrier Military School students. They still had their original beds, mattresses, desks in those rooms, and it almost looked like a prison courtyard there. And the school let us each pick one of the rooms to use as a study room. What they didn't tell us was there was no heat out to that building any longer. So it was kind of hard to study there if it was January or February. And there's still one person on the faculty that was here when I was a student, who came here when I was a third-year student, and that is Dr. Foster. And Dr. Foster's not here, is he? My main experiences with Dr. Foster were in the clinic, and also back then in the main building, in the office suite where the Associate Dean for GME's office is. We actually had a birthing center, and we delivered babies in the main building of the school and then sent the mothers and babies home in less than 24 hours. Now, looking back as a pediatrician, that was a really scary thing to be doing, and I'm not so sure that the backup down at Greenbrier Valley was that much better back then. You know, we had a lot of t-shirts and sayings back in the old days, and this is one of my t-shirts for WVSOM. We're very sure of our medicine. You know, we were into Dio's Care and all kinds of stuff in West Virginia back then. That was me back in the old days. About 40 pounds less, maybe 30 pounds less. And this is these are the class officers for the class of 1979. I'm the second one on the left. The first gentleman works emergency rooms, mostly here in West Virginia. The gentleman with the beard, the third person, we all had beards and hair back. It was the 70s, that's what you did, is a dermatologist in Zanesville, Ohio. The young lady, Dr. Linda Eckel, is a family doctor in Milton, West Virginia, between Huntington and Charleston. And the last gentleman, Dr. Sinecrope, is an internist down in Florida. Most of the people in my class did go into primary care. A lot of us stayed in West Virginia. When we have a fall meeting at the Greenbrier and we have the midwinter conference, statistically, my class still gets one of the highest representations percentage-wise. There were about 40 of us in the class, and we generally get 8 to 10 people at all of those functions. We were also the first class to be 100% life members of the Alumni Association, and we're big givers. We're big givers because we really believe in this school. Do you know who that is? J. Rockefeller, Senator Rockefeller, but at the time he was Governor Rockefeller, and the first 2 years that I was a student here, he did everything within his power to try to get this school closed. He did not think that the state of West Virginia needed, at that time it was 2 medical schools, because we were actually the second medical school, and then Marshall was started a year or two after this school was started. He felt that everything should be up in Morgantown. By the time I graduated, he had changed 180 degrees, and he really bought into the notion of rural medicine. And even though to this day some of his medical views differ from those of physician views, he's still a strong supporter of rural medicine. And most of you will not remember who talks at your graduation, but because it was a Rockefeller and because of the polarity that we had felt from him the first couple of years, he was a good speaker. And I don't know if any of you all know who Dr. Lemley is, who retired last year. Dr. Lemley came to the school when actually I was a 4th-year student, so I never had Dr. Lemley, but I worked with him through the years on faculty and then as an assistant dean, and just wanted to show you what he looked like back in the old days. So I was supposed to say a few words about, well, I was under the title of being a successful rural primary care physician. I think that's what the title of this segment is. The first thing I wanted to talk about is, what does successful mean? Does it mean what the price of your house is? Does it mean what kind of car you drive? Does it mean, how expensive your clothes are? I don't think so. I think successful means that when you walk into work every day, you have a smile on your face because you enjoy doing what you're doing. It doesn't matter whether you're a family doctor, a pediatrician, general surgeon, whatever, even a psychiatrist. I don't know if Dr. Workman ever has a smile on his face anyway, but it's liking what you're doing. And medicine is not just a job, it's a career. It's something that at 5 in the afternoon, if you're not finished, you're not finished. You generally cannot walk out the door and leave that patient for the next person because 9 times out of 10, there isn't a next person. So to me, the first thing is of being successful is liking what you do and seeing that as your career. The next thing is, and maybe this is on the same level, is being happy when you walk into the house. And so I've been successfully married for over 39 years, and I have great kids, and I have great grandchildren. Not great-grandchildren, but very nice grandchildren. And a nice social life and a nice religious life. And I think that's another part of being successful, is having that when you walk out of your job or your career with a smile on your face, you walk into your house and you have another smile on your face. And that's what makes you successful. As a pediatrician, which is something I went to medical school to become a pediatrician. I already knew that's what I wanted to do. I didn't flounder around. My head got turned a little bit towards family medicine when I was here at Lewisburg, and then I resaw the light and realized now it's pediatrics, which is family practice for kids. Very rewarding practice to have been in the number of years that I practiced. And although there were a few tragedies along the way, and in pediatrics, a tragedy is a real tragedy, most of the time it's a happy practice. Again, I walked in every day with a smile on my face. I walked into most of the time into the exam rooms to see the kids with a smile on my face. I looked at the parents. I didn't always have a smile on my face. We consider the dream job for a pediatrician is a pediatrician in an orphanage, because you can see why. Just the kids. Through the years, I've participated a lot with the school here at Lewisburg and graduate medical education at Charleston Area Medical Center. And what's also been rewarding to me is to now have students that are coming through my region and graduates of the school who are my patients from when they were born, and some of them may even become pediatricians. So that's what successful is. What's rural? Well, when I was growing up, we didn't have these words rural and urban. We sort of had country and city. And Charleston, where I grew up, that was not considered city, that was considered town. So to me, because I'm from Charleston and because I practiced in Charleston, I don't like being looked at as an urban physician or a city doctor. Most of my patients did not come from within the city limits of Charleston or the nicer neighborhoods. A lot of my patients came from Clay County, Boone County, Putnam County, Fayette County. I mean, that's the draw area for the Charleston area, is 300,000 people all the way from Montgomery, West Virginia, down to Hurricane, West Virginia. And up north, I had a nice contingency of patients that came from Roane County, and again from Boone and Logan County. People drove up to Charleston to see me. I think that rural is a state of mind, and I think that how we're taught to treat patients here at WVSOM is what rural medicine is, whether you're practicing it downtown in Charleston or whether you're practicing it in Logan. You're practicing rural medicine, because rural medicine is being connected with your patients and liking to be with the people that you're serving. That's what rural is. And so what's primary care? Well, primary care when I was here at the school was family medicine, family medicine, family medicine. That was the mantra, family medicine. I'm sure on my application I wrote something about maybe I would consider family medicine, because you had to have those words. Now, now primary care is, family medicine, internal medicine, pediatrics. Some people have stretched it to OBGYN, general surgery. All of us on this panel today practice primary care because taking care of people is our primary function. And to me, that's what primary care is. It's a state of mind. It's how you take care of people. It's not just the name of the specialty that you're in. And it may be the location that you're in. So when we have a general surgeon on the panel today who's practicing in Logan, it's not something that jumps out at you as being rural, but it's rural and it's primary care. For me, West Virginia is location, location, location. If you want to live in a larger place but practice in a smaller place, we have examples of people who live in Charleston and practice in Logan. If you want to live in a smaller place, you can live in a smaller place. But the advantage with our interstate system and with the proximity of hospitals to highways and all, West Virginia is a really great place to practice. And it's a great place to have lifestyle. I grew up in the Charleston area. I was given a lot of advantages in that area, but I was also able to travel because West Virginia is pretty easy to get to major cities within 4 hours, even by car. And so my wife, who is from Long Island, New York, who considers Charleston to be a suburb without a city, very quickly adjusted to the fact that you can get anywhere you want in 10 or 15 minutes. You can know who your kids are with. You can get to their schools pretty fast. There's lots of activities. There's just lots of cultural advantages all over the state. And you become a large fish in a smaller pond. So when I go to Kroger's on Sunday morning to pick up something that we might need for breakfast, it's not uncommon for me to run into some of our legislative leaders, one of our senators doing her grocery shopping, and to stop in the aisle and talk. And, I'm not anybody special, but she knows who my family is, and she knows my kids' names, and she asks how everybody is doing. When we tell that story to relatives that still live in New York, it's like, really? We've never even been to Albany to see what the state capitol looks like. I mean, they don't have a clue. They're little fish in a big pond. West Virginia, you can get to know a lot of people. There are a lot of advantages to raising your family here. This is what puts a smile on my face nowadays. Since I've been the regional assistant dean in the South Central region, my office is in the West Virginia University building on the campus of CAMC Memorial Division in Kanawha City. When I was a fourth-year student here, they would not let me do a pediatric rotation through their department at CAMC because I was a WVSOM student and there was not to be any mixing of the money. By the next year, I was the first DO resident to do a residency at CAMC. And at that time, the Department of Pediatrics was at the Memorial Division. We didn't have Women and Children's Hospital yet in Charleston. So a lot of stuff happened, years and years and years, and practice, and then hired by the school. And lo and behold, CAMC gave me a couple offices in this building, and the foundation didn't crack. And the office that they gave me personally was the same office that the chair of the Department of Pediatrics had when I was a resident. And within a year or two of us organizing the South Central region and getting things off the ground, we were able to get this sign on the front of the WVU building. Now, it does have the WVU Health Sciences Center above us, and CEMC is below us, but we are on the front of that building. And every morning when I go into that building, I have a smile on my face because I know how far we've come with osteopathic medicine in this state. That's my story.
I'm Derek Harmon. I'm a graduate of this college from 2008, actually. I was anatomy GTA here. Currently, I'm doing family practice in Logan County, and I'm the guy that lives in Charleston and commutes 55 minutes to work every day to work in Logan. So just tell you a little bit about myself. So I do family medicine in Logan, very rural area if you have not been there. There is a statewide campus. We have lots of students, and I do precept those students. I am an outpatient-only family practitioner. I do not do any inpatient at all. I have admitting privileges to Logan Regional, but I just choose not to do that because of lifestyle. And getting back to what Dr. Rubin had talked about, I'm Monday through Friday, 8 to 4. I get to go home at night, and I answer my beeper if there's critical labs or something, but I don't do any hospital work. And I'll get back to, kind of choosing practice later on, but that's kind of where I'm coming from. I work on the weekends in the emergency department sometimes. I'm starting at the Huntington VA pretty soon to work in the ER there, but in primary care, especially family practice, you have those opportunities to work in the emergency department in a lot of institutions, which is a big plus. So I was born in Bluefield, West Virginia, which is just south of here. It's a rural community as well. Used to be a city, I guess, but now is becoming more and more rural, I suppose. Fewer people live there. I had initially planned to go back and practice in Bluefield and be a family doctor. And when I started WVSOM, like everyone else, put that on their application, but I actually meant it. I started out actually in medical school. I got interested in psychiatry and ended up doing some psychiatric residency over in Charlottesville at UVA, and quickly decided, wow, this is not what I wanted to do. I wanted to be able to do more, even though I'm still in love with psychiatry, and I can attest to how much psychiatry I actually do in my practice, which is a huge amount because there is no psychiatrist within like 50 or 60 miles or something like that. So I started out in psychiatry, quickly changed over to family medicine and Wellmont Health Systems, which is down in Virginia near Kentucky, Tennessee border. It was a very rural practice, and we saw a lot of rural stuff, and I'll get to that in a minute too, but had some chances to go over to Kingsport and Bristol to do some of my, ICU and emergency where you needed a higher volume. So I guess the main part is, why did we choose rural, medicine? So basically, at the end of the residency, I had a lot of big decisions to make. First of all, what type of practice do I want to have? And that was my first big decision. And I am a hospital-owned practice, meaning that I get a salary from the hospital and see as many patients as I can. So it's a hospital-owned practice, although I run the practice myself. So that was the first big decision. I hate paperwork a lot, and I did not want to deal with insurance companies and everything that went along with owning my own practice. So, there are a lot of big pluses going either way, and we may get some different perspectives here, but it's hospital-owned, and so that was the first kind of big thing that I had to figure out. The other was, what type of lifestyle did I want to have, and like I told you, I chose, to be outpatient only. And those jobs actually are becoming more and more available. Even when I was in medical school, it was family practice opportunities were, inpatient, outpatient, traditional practice. But now they're becoming a little bit more available to obtain if that's what you're interested in. So that's another thing. I just decided I want to do the outpatient only. And then kind of the second big thing that that you need to figure out is where you want to practice. So I probably had 6 or 7 months of medical school training in Logan, so I was familiar with the area. And I approached Logan at the end of residency and said, hey, I may be interested in coming back to practice in this community. And I'll talk about some of the reasons that I like rural medicine, but I think the first thing that really caught my attention is they offered a lot of great incentives to come back and practice in a rural community. And that's something that you need to really look at and balance with all of your loans that you're going to owe and signing bonuses and stuff like that. But there was a great incentive to come back to a rural community that, frankly, I did not see in larger cities. I looked, it took me a year and a half because you got to start early in residency figuring out where you're going to go. I just didn't find the type of opportunities and incentives that I could find, in a rural community, not so much in larger cities. So that's one of the first things that got me there. But once you're there and you start practicing, you realize that you are quite a big fish in a smaller pond. Everybody knows you in a small town. You cannot go to Walmart without patients pulling you aside and talking to you about their problems, and then you have to pretend like you remember them, which is really bad. It's my first year there. I haven't got to know everybody yet, so. But there some of the other things. The job is very challenging when you're a rural primary care doctor in any primary care. There's not a lot of backup. Although Dr. Paul and I work in the same hospital, and I do call him a lot, so it's good to have some backup. But really, you're the only guy there. Although we have specialties in Logan, I can't get them in the next day, for example, unless there's an emergency or something like that. So you're really left stuck doing it all yourself. So it's a very challenging position. And if you like that, you need to make that decision that day type of person, then, rural healthcare is very much like that. There's more rural places than Logan, not much more, but, it's a great place to practice because it's very challenging. It really it's tasking. Let's see. The other big thing is that I feel like I make a really big difference in the town. Logan's small. It's extremely rural. Very impoverished. And more so than I think maybe a larger city where you see your patients and maybe occasionally out and about. But working in a small town, you get to take care of entire families. I have multiple families that their entire family comes to me, including kids all the way up to geriatrics. And that's a very good feeling that an entire family trusts you to come for their entirety of care. But making a difference, I used to be the team football sports medicine doctor there for a while for the high school team, and your ability to give back to a community in a small place. I feel anyway, is much. There's much more substantial, a lot more substantial when compared to maybe just working in a town of 750,000 people. And it's nice to be the country doc that anybody can come to. I have troopers and stuff that stop by, to say hi, and a lot of locals and stuff. And it's I live in Charleston, but Logan is not that bad of a place to live, actually. So I think that if you're considering rural care, you should really think about, first, what type of practice you want. If you want to work inpatient, outpatient, how far are you willing to travel? Like I said, I travel about 55 minutes every day. And then look at incentives and stuff that rural hospitals are willing to do. And then also, if you want to be the doc that everyone knows in town. Some people are not comfortable with that. But if you go to a rural place, often everyone knows your name. And I like that, actually. So I feel like I can give back a little bit more. So.
I grew up in small town West Virginia. So returning to small town West Virginia was an easy decision for me. As far as rural medicine, I mean, these guys have already said a lot of the things I would have said to you. So I'll tell you a little bit about myself and where I come from and how I ended up where I ended up, and go from there. Just kind of wing it. So I grew up just outside of Oak Hill, West Virginia. Prior to medical school, I was a respiratory therapist for about 10 years. So I'm very comfortable in the hospital setting in the ICU. I knew when I got here to WSOM that I wanted to do internal medicine. So the reason I knew that was because of my previous work experience. I knew that if I wanted to specialize, medicine was the gateway to any specialty in the medicine realm that I wanted to pick. For me, it would have been cardiology or pulmonary. But after spending time in each one of those rotations, I thought, there's no way I could do this every day forever. It was just too focused, and my attention span just wasn't for that. I like having variety in my day. So I can see patients in the ICU, manage a ventilator, and then an hour later be at the office seeing a patient for their high cholesterol or their diabetes, and and that's just nice if you're made that way. So I knew where I would be working before I graduated medical school. I'd already reached out to hospitals in the area in which I wanted to live, and kind of took the bull by the horn, so to speak. I didn't let them come to me. I made a decision where I wanted to live and try to make things happen from that route. So rural medicine. I think Dr. Harmon said it best. When you really get to know your patients, you will see and treat whole families. I don't do kids. That was one of the reasons I wanted to do internal medicine. I had enough of that as a respiratory therapist. RSV season, you see more kids than what you really want to see. And again, I like the ICU, and I like taking care of the sick patients. But yet I also like the mix of taking care of well patients too. I like procedures, but I didn't want to do a surgical residency. That was, again, too much. My attention span just wasn't made for that. So being in the ICU, I get to do the procedures I like to do. And being an internist, and I guess the same would be true for family practice too, you get to pick, especially in a rural area, you get to pick and choose from the specialties and that which you like to do. I do, on 2 days a week, I work at our hospital's vein center, which I evaluate and treat venous disease. I'll do stress tests. I'm in the process of getting certified for echocardiograms and carotid Dopplers to read those. So, you get to pull from that which you want to do from the specialties, but not have to spend a full 3 years just to do those things. So what is successful? I think that Dr. Rubin I would like to use his definition of successful, but I would like to add, successful is making or affecting change in your patient's life. whether they realize it or not. There are patients that you will touch and improve their quality of life, and they'll never know it. You know, and it's not the most rewarding thing, you know, as far as praise, but you know it, and that's what's important. Then there'll be people that they realize that you've truly helped them, and they're so appreciative. You know, taking care of rural patients is, they're very appreciative of what you do for them. Most of them, you know, it's like anything else. You'll have some that aren't. They call that life. So, you know, rural medicine's tough in the way that, as far as the barriers that patients have to accept your suggestions or the care in which you're trying to provide for them, is varied. You know, it depends upon where they've come from. You truly have to understand what their situation is to affect change in their life. And that's probably the most difficult part, is trying to understand, because they don't want to tell you everything. You know, they don't want to tell you, you know, their baggage, but that takes time. And as they get to know you as part of the community, because you will run into them, and no, you won't remember them all. And in some ways that's a good thing, because, you know, you really remember the tough ones or the bad ones. You know, you don't forget those faces. And the good patients takes you longer to, hate to say that in good and bad patients, but it takes you longer to get to know those, unless you have some type of bond, commonality or something you're sharing with that patient. But it happens. You'd be surprised at the number of patients you do remember. Did I hit on points? I think that's about all I have. Yes.
What are your hours like?
My hours, well, they vary. When I'm on what we call medical backup call, which is unassigned patients, I'll work, you know, anywhere between 8 and 12, 14 hours a day. If I'm not on call, then, you know, I'll go to the office at 8 in the morning and I finish when I finish. How you structure your practice will have a whole lot to do with your hours and your lifestyle. I do inpatient, outpatient. I don't work in a group, so when I'm always on call for my patients unless I arrange otherwise. And I wanted it that way. In residency, I spent a third of my time with hospitalists, which was a great experience. But I noticed that there was a lack of continuity. I would discharge the patient today, and in 4 days, 5 days, a week, they were back for the same problem, because they couldn't get into their primary quick enough, or, you know, there was not enough, the follow-up wasn't there. So when I discharge a patient, I discharge them to myself, so I can get them into my office and try to keep them out of the hospital, and try to keep them from using the emergency department as their primary care. Because there's a lot of people out there that still use the ER as their primary care.
I'm a psychiatrist in Beckley, West Virginia. I graduated here in 2010. Any psychiatrists in this room now? Future psychiatrists? People who don't like to smile at all? No? No? Anybody? I didn't see any hands. You? Are you top of the class right now? Yeah, like, so you're top of the class right now. You're the smartest one here, right? Yes. Just say yes. Just say yes. Just say yes. Okay. A little more cerebral, maybe. Okay. It does fall in that primary care field. So as we trickle down this panel, like things get kind of said over and over again. But I graduated in 2010. I was born in West Virginia, born in Winfield. Lived there until about 5, and then moved to Virginia Beach, had a really hard life growing up on the water and doing those sort of things and having a good time. But my family was always back in West Virginia. We had all well, I have 2 half brothers and a half sister that were back in West Virginia. My aunts and uncles and cousins and other relatives were all here in Boone County. So we would always go back to Madison and Danville area and go down 6 Mile Road and past Big Ugly Creek and go down that place and play on the farm and do all that stuff. I go there in the summer times. I love that stuff. It was, I had the beach, but I always was drawn back to the mountains and big open spaces and things of that nature. And I still love going back home, but or I say home back, like in Virginia Beach where my parents lived. But I was always drawn to this area. When I graduated high school, I went to WVU, got a couple degrees there, and then applied here. And so any WVU people? WVU? Marshall? I'm sorry. So I went there, got a couple degrees, came here in 2006, and as I'm getting the call from the people here to come and talk, I'm telling my wife, and she is a former student here as well, that it's been almost, I guess, 8 or 9 years since this guy and myself were in the same classroom. We were part of the first big class of 200 across the hall. The class before us was 75 or 100 or so in this room, and the first years were over across the hall. And I just can't believe that 8 or 9 years has gone by that quickly. There's been 2 or 3 2 things in my life, having kids and going through medical school, that every day is just a marathon. It's forever, but yet it goes fast, and somehow that doesn't really match up. But you remember every moment of every day, but 3 years, 10 years, 9 years go by so quickly, and how that works, I don't really know, but your time is taken up. And I know days like this for you guys, I think come to days that were similar, like we didn't have this when I was in school, but come here and hang out, pick up a couple morsels of knowledge, but basically, I get to stock my refrigerator with bottles of water and soda and get a couple meals out of it, and then hit the books again. But so we got here, and when it's time to go to your statewide campus places, my wife and I, we met during school, and she's a pediatrician now in the same building that I'm in, and her family's from Clintonville in Lewisburg area, right off Sound Black Church exit. And we were planning on wanting to stay in this area, and we knew we wanted to kind of come back to Beckley, Charleston, Lewisburg-ish area. That it got me, close to Virginia line, sort of, and I had some family in Charleston too, and her family all being in this area. So we knew we wanted to go to Beckley. It was a big enough place that there were some things to do, but small enough that you got to do things with the physicians. Beckley, there wasn't a residency program. There was a family practice residency that kind of was there, and it might still be there. I think it was possibly fizzling out soon, but so you get to do a lot. You're practicing with the family doc, with the surgeon, with the internist, with the psychiatrist, and you're their next person. So you have to be hands-on, but also, you're in a big enough area that there's things to to do and see. So. In school, I wanted to be a psychiatrist. I found that out pretty early on. I liked neurology. I liked family. Family has a ton of psychiatry in it. And neurology is, a third of my boards are neurology based. And, so I'm kind of drawn into that. I wanted to be part of the continuity of care and, be a person that, had patients and made them feel comfortable, and that, psychiatry is a real personal field, and, being in an area, and that's kind of where I think this model really presents itself well, that you're kind of taught to be a very open person and someone that people can connect with and feel comfortable with, and it's all about the bedside manner that you get taught here. And you'll notice all that stuff whenever you guys go out, that you're going to be a little bit different, a little more talkative and chatty, and your notes going to be a little bit longer and more detailed, and pay attention to a couple more things than the other people that you might rotate next to. But as I get to third and fourth year like rotations, I kind of get pulled the family medicine side a little bit closer. I kind of strayed from the psychiatry aspect, and then I go on my psych rotation, and my first interview with a patient is lady that is, she's in her hospital bed there, and she's got these like white rimmed glasses on. They're completely blacked out, and she's got 2 or 3 layers of clothing on. It's not that cold outside, and they're all kind of dirty looking and grungy, and she's doing some weird things with her hands, and we start talking, and she's come and find out she's a professional clapper and like a balloon artist. And that was her source of income. I had no idea what those were, what that meant, and her thought process was sort of it was all over the place. I could not get anything out of my interview with her, and I'm trying to think of how am I going to get this back to my preceptor, and then I'm like, well, I'm going to go talk to the doctor about your medication and what we might be doing, if you're going to be admitted or not, and she said, well, make sure no medications like interfere with my kids and with my twins that I'm about to have. And I'm like thinking it looks nothing like she's going to have twins at all, but while she's talking, she was having these weird hiccups in her voice, but that was apparently her talking with aliens or with extraterrestrials while we were talking. And the twins in her belly were named Alpha Mike and Beta Kins, and they were at this point. I'm like, this is fantastic. You can't get this at all in anything else. I mean, there's nothing that you can teach me that teaches me how to handle this, and there's no blood level for it. There's no lab. There's no image. I mean, there's no image for it. It's just what are you going to do with this? This non-tangible, abstract medicine, which really didn't fall. I'm a pretty organized, structured guy by nature, but I always, at that point, I'm like, we got to go back to psychiatry, and everyone's story is different, and depression is depression, and diabetes is diabetes, but your depression is there for a different reason, and whether it be divorce or job or pain or anything else, the story is different, and how you react to the story is kind of where the relatableness that you get here, and how they're like your ability to make people feel comfortable. You really pick that up here, and doing that in a place like Beckley, anywhere in West Virginia really, or anywhere like rural, I guess you want to air quote that, I guess, but anywhere where you can be known and recognized, and people feel comfortable talking with you. That's really why I chose the area. Apart from the family stuff and being close to the relatives and whatnot, it was, pick an area that you not only were one of the residents, but you understand them the most. Everyone knows the person that comes here from a completely different area, and, they just don't relate to the people as well in the area. And people in rural West Virginia, it's a different, they kind of stick together, and they want, one of their own talking with them, and, if there's 2 people, they're going to pick the one that they relate to the most, whether they're both equal or maybe the other person's better, but they're going to pick that person that they feel comfortable with. And that's ultimately why I chose the area, because I felt like I could make a difference here, and I could relate and make some people feel comfortable, and maybe make a difference in some people's lives, and hopefully that they recognize it. If they don't, then, then they don't, but I do. And, that's ultimately it, guys. Any questions?
So you said that you had that lady, the white rimmed glasses.
Yeah.
So was that what was telling you that you should do psychiatry, or was
No,
there something that?
I wanted to do it before. I kind of strayed a little bit toward it kind of brought me back in, like just, an interesting thing that you don't see every day. And, I guess I didn't really hit too much on, briefly. I know he's got a talk here and got a video for you, but I'm going to practice now with 4 other people. They're all psychiatrists. There's 8 psychiatrists in Beckley that are on the current rotation that I'm on. As far as call schedule goes, I do inpatient and outpatient. It's a 69 bed unit, and I'm gonna practice with. They're all family members. I'm the only non-family member in the practice, and that was, I think, when I was in my third year trying to get a rotation for psychiatry, they were going to send me to like Virginia and Roanoke somewhere like 2 weeks after I got settled in Beckley, and I was like, no, we got to figure something else out here, and started knocking on some doors and had to have an interview with this practice that I currently practice at now, and they, they accepted me, and then my wife is in pediatrics, and the office manager of the psych office that I work in now, his oldest son is my wife's boss. He's a pediatrician, and so we're all in the same building, and they like her a lot better than me, and that's kind of why I'm probably where I'm at now. Is the psychiatry office manager likes my wife a lot more, and so whenever we left to go to residency in Charleston, they kind of gave us more of a offer to, if you come back, we'll have jobs here, and that was always, they kept they kept in touch, and we came back and did things, and I do I do practice in Summersville and Bluefield, and travel almost daily to one of those two places. Work at a community mental health center in Summersville and work at a private psychiatric facility in Bluefield, and do ECT and drug abuse treatments and a little bit of obesity stuff I'm working on now, as long as general, as well as general psych and adolescent and geriatric psych.
It's a pleasure to be back on campus. We didn't have anything like this when I was a student here, and just looking outside, there's a lot of change that's going on the campus. I think it would certainly be a very exciting time to be a student again here. But I born and raised in West Virginia. I grew up outside of Fairmont in a small town, went to North Marion High School, did my undergraduate at West Virginia Wesleyan, and then prior to coming here, met my lovely wife, and she followed me through my 4 years here. Prior to going on to general surgery residency, I did an American College of Osteopathic Surgeon preceptorship with Dr. Mark Harko at United Hospital Center before they had their nice new state-of-the-art hospital at the old site, so to speak, who was actually an alumni of WVSOM. And it was very influential in helping me to get where I am at now. Went to what was Massillon Community Hospital and Doctors Hospital of Stark County at the time. That was bought out by corporate America, so to speak, and the two hospitals merged, and it's now named Affinity Medical Center, but small community hospital in Massillon, Ohio, outside the Akron-Canton area. And it truly was a community hospital in the sense that it was close to rural farmland in the Midwest in Ohio, a large Amish population that frequented the hospital, which was nice. So, in keeping with that theme, and my wife basically making me promise that if I did 5 years of general surgery in Ohio, that we would go back home to southern West Virginia. And as she's from Boone County, we're now in Logan. But needless to say, my intentions all along were to come back to rural West Virginia, and and without getting somewhat philosophical, staying true to the roots and ties that we had. As much as osteopathic medicine is a family, your immediate family is very important too. And when you're a surgeon practicing long hours and you have a young family and a wife and things, family support's very important, when you can't be there. So ultimately ended up in Logan. As Derek said, I had a wonderful opportunity to start there. We started roughly at the same time and, hit the ground running. And for the last almost 2 years, I've been there and couldn't be happier with my choice. Part of being, successful, as Dr. Rubin had said, and also being an osteopathic physician, I think you have to not only have a professional relationship with your patients, but you really need to have a personal relationship. And regardless of whether it's family medicine, general surgery, obstetrics, gynecology, psychiatry, internal medicine, you know, what you learn and are taught here on a daily basis is going to be reflected in the care that you provide your patients. And you may not realize it now, but everything will come full circle and will come together when you start and develop your own practice. And as you get to know your patients on a professional level, you get to know them on a personal level. You know, your kids go to the same preschools, the same daycare, you live in the same community, you shop at the same grocery store, you go to Walmart, and what turns into a quick trip to get, you know, bread and milk and, you know, whatever else our son would need at the time, you know, some bananas or something, you're talking to a patient and you're there for a half hour before you know it. And I think that's really important. And as Derek said, you develop those community ties. You know, you're part of, whether it be civic or nonprofit organizations in the community. You're also a working individual just like everyone else is in the community. And you really start to develop those personal ties with your patients. And before you know it, you know, the nursing staff and ancillary staff at the hospitals in your office, you know, coming in a referral, and you're operating on them, or you're operating on the local judge's daughter, you know, or the hospital supervisor, you know, comes in the ER and he's sick, and you've got him in the OR before you know it. So it's really important to develop those, you know, personal relationships, and you really get attached to your patients. And it's not so much work, you know, or a job. It's, you know, kind of a lifestyle, and you just kind of blend right in with everyone else. And that, you know, kind of goes along with, you know, being successful in an osteopathic physician, regardless of what specialty you're in. I can't advocate anymore that general surgery, obstetrics, and gynecology is part of the family care realm of medicine. You cannot have a community hospital in rural West Virginia or rural USA, regardless of where it be, without having a general surgeon. Otherwise, you're a critical access hospital, and you know, you may or may not have, you know, a whole lot of inpatients. But I think it's extremely important that we continue to advocate and make obstetrics and gynecology and general surgery part of the primary care discipline.